Day 3 is going to be on the day of END. Okay, so thank you for cooperating. Then we'll decide when to do END. I'll request the cerebellum people to give me some slot for the END. Throat is bad, but let's hope I can manage today. Okay, lot of medicines. Let's see how it goes. So plan for today is hepatobiliary first, then trauma. Then we'll see how much we can do. Okay. And today's day 3, but actually it will be day 2. So day 3 is going to be day after tomorrow, which is the END day. Okay, so just be aware. Where you will do urology, general surgery, plastic, all those. No, tomorrow is BTR class. So I don't know how to fit it. No, tomorrow is not off. Tomorrow you have some other, you have BTR class tomorrow. That's why. My original class is on Wednesday, day after tomorrow. You know. See, we'll fit my END which will be left, you will fit it somewhere. I'll request the team. Okay? Okay. Just stay tuned for day 3. Let's see. Let us finish today first. Okay, one step at a time. So these are the IMP topics, very important topics for NEET as well as for INI, which most of you are appearing for, right? So let's get started first with liver. Now, in liver, the infections are what they keep asking. The first infection is hydatid cyst of liver. And who gets hydatid cyst? I always ask this question. Who is supposed to get it? Who is supposed to get hydatid cyst of liver? No, no, no. It's not dog. Dog does not get. No. It is okay. Sheep is the intermediate host. Who's supposed to get it? Okay. Now, the parasite is Echinococcus. Microbiology, you must have learned. Definitive host is dog, which means dog is supposed to harbor the reproductive phase of the parasite. So from the intestine of the dog, the eggs will be laid. Eggs will go in the feces, and when the sheep feeds on the grass, the sheep will ingest the eggs. They will mature, multiply in the sheep intestine. They will become larvae, and these larvae will reach the sheep liver. How? How will they reach the sheep liver? Usually, it is the liver. How are they reaching the sheep liver? Very nice. From the intestine, they puncture the enter the portal vein. Portal vein से sheep के liver में it will go, where it will form the cysts. Man should not get the disease. Man is the accidental host. How does man get the cyst? Also dead end, correct. How does man get it? So very nice. Man gets it by fecal consumption. Okay. It is not contact with dogs. It is fecal. So if you eat contaminated food and water with the eggs of the hydrated, you will get it. So normally when man gets the hydrated cyst, usually it will reach the liver. Liver is the most common site, followed by lungs. What does it do in the liver? What does it do in the liver? It will form the cyst. Then what? ठीक है ना, cyst है तो क्या बड़ी बात है? What does the cyst do? Usually it is asymptomatic. Okay, usually it will be asymptomatic, or the person may have a hepatomegaly. So either he will present by chance. So if all of us undergo an ultrasound, some of us may be having a hydatid cyst. It may present with a hepatomegaly. How will you diagnose it? What is the first step? Any patient with hepatomegaly, what do you do first? Always first step, LFT, USG. On USG, you may get the hydatid cyst like this. This is the water lily, or the floating membrane sign. Okay, water lily or floating membrane, usually it is diagnostic. Any doubt, you can do CT. So best imaging is going to be CT. If there is any doubt, you will do CT. FNAC biopsy, contraindicated. Because if you rupture the cyst, he can get peritonitis, there can be dissemination, he can get anaphylaxis. What is the ultrasound classification called? Very nice. It's also called as Garbi classification of hydrated. Okay, which you will study in radiology. Now, patient comes and you have diagnosed hydrated cyst. How are you going to treat? Does everyone always require treatment? No. Then how do you decide the treatment? Very nice. So treatment depends on activity and the symptoms. If inactive, no treatment is needed. Okay, that means it is well contained. If active, Garbi's USG classification. If active, then what to do? Then the first step always will be to give Talbot albendazole so that it gets sterilized, and then you decide what you want to do. Either you do pair procedure. So albendazole normally will be 400 mg for 3 weeks. And then you do pair. Now pair, the full form, remember, it's puncture, aspiration, injection, reaspiration. Okay, puncture, aspirate, inject, reaspirate. This is normally done by radiologist. Usually this will do the job. You puncture the cyst, aspirate the fluid, inject a spolicidal agent like hypertonic saline, betadine. Okay, and then you reaspirate, job is done. But sometimes it is contraindicated. Like if it's a deep cyst, or if it is honeycombed, multiseptated, or there is a cystobiliary communication. In these cases, where it is contraindicated, you will have to do surgical removal. What surgery do you do? What is the surgery? So remember, for cyst, you always have to do cyst removal, which is called as pericystectomy. Okay, pericystectomy. No, when you are puncturing, you are aspirating, so it will not rupture. And you are injecting spolicidal agent, so this is safe. Per is safe. Cool. So that is about hydrated. I feel you will get one question from hydrated in the exam. Important topic. Okay. The other liver disease that you should know is liver abscess. What does abscess mean? What is the meaning of abscess? How to know cystobiliary communication? MRCP. Abscess means local pus collection. Okay, it means local pus collection. If it is in the liver, it is liver abscess, right? Now, liver, there are two types of abscesses that you must know. First is called pyogenic or true liver abscess. Which bacteria is usually responsible, and how does someone get it? Usually it will be E. coli, gram negative, or Klebsiella. Okay, E. coli, Klebsiella. How does one get the infection? Very nice, excellent. You are giving good answers. It goes from the bile duct. That is called as ascending cholangitis. So the infection from the biliary tree goes up the biliary tree into the liver and you get multiple liver abscesses. How does the person present? He will have severe pain, any abscess, severe pain in right upper quadrant, plus high fever, plus since this is liver abscess, hepatomegaly. And usually it will be painful. The liver will be tender, usually. Right? So that's how the person will present. The other abscess, which is not actually an abscess, it's a fake abscess. Like, like how you have fake people. This is a fake abscess. That is the amoebic liver abscess. How does amoebic liver abscess reach? How do you get? So it is fecal. First, you get amoebic colitis, which is endemic to most of the countries, like most of the parts of India. So first you get this amoebic colitis. And from the colon via portal vein, it will go to the liver, right? The trophozoites will puncture the GIT, they will enter the portal vein, they will reach the liver. What will they do in the liver? This is most important. They will cause liquefactive necrosis. If you know all this now, how much ever they twist, you will not have a problem in these kind of questions, right? So they will cause liquefactive necrosis because it is producing a toxin. The name of the toxin is histiolysin, Entamoeba histolytica. So histiolysin. So liver starts breaking up, and this broken up liver has mainly dead hepatocytes plus RBCs plus few WBCs. Okay, so mainly it has RBCs and dead hepatocytes. Few WBCs, it looks like this. This is your anchovies pus, sterile pus. Okay, sterile means you won't get any bacteria. Why there is no bacteria? Why is there no bacteria? Where is the bacteria gone? Okay, can you find trophozoites in the pus? So can you find the parasite? Yes, no? Or no? I am saying sterile. No, you don't find it. No. Because the parasites are not in the pus. The parasites are in the border. So this is the pus. The parasites will be in the border. It's like, you have some friends in your life who do damage from outside. They'll keep making remarks. They'll keep making, comments about what you do, which will kind of disrupt your mentality and you will damage yourself. Yeah, they are like snakes. So this parasite is like that. It's not directly doing anything. It is sitting at the border and just throwing. It is just throwing the toxin, causing the liver to break down. So when you have amoebic liver abscess, usually there is history of dysentery or amoebic colitis. Okay, this history will be there 1 or 2 weeks back. And now the patient has fever. But this fever will be long duration and low grade. It won't be very high grade unless it's secondarily infected. And you will also have a hepatomegaly. But you can make out chronic inflammation. It will be of long duration. It will be of weeks to months. Not like a pyogenic. So it's not a real abscess. There will be dull aching pain. Okay. So anyways, whatever is the case, first step, what will you do? Person with a liver disease. What is the first step? It will always be LFT plus USG abdomen. Okay. LFT may be normal in either cases. They may be deranged depending on the inflammation. But USG abdomen will show you a collection in the liver. How do you know it's an abscess? What will the collection show? What will the collection show that will tell you it's an abscess? Very nice. It will show debris. Kachra, right? Kachra or debris. So that tells you it's an abscess, but you don't notice pyogenic or amoebic. So investigation of choice is going to be aspiration. It will be image guided aspiration. That will confirm whether it's a pyogenic or amoebic. That's it, simple. You want to see is it Anchovy pus, is it frank pus? You see that, you get the diagnosis. You can do microscopy of the pus, you may see the organism. Ring enhancement only means vascularity of the abscess. There is, yeah, but that's on CT scan. Okay, ring enhancement can be seen in either, but that is on CT scan. Now treatment. Pyogenic abscess treatment. Culture will be negative in amoebic, yes. That is why it is sterile. No, you are aspirating, no? So it's not contraindicated. For pyogenic, the treatment is going to be drainage. Drain the pus. Plus, you will give antibiotics. Okay, drainage can be pigtail drain or drainage can be surgical drain. Doesn't matter, but you have to remove the pus. In amoebic, the treatment is not drain, the treatment is medical management. So normally what you will give is going to be double dose metro. Right? You will give double dose metro. Means 800 mg TDS for 10 days or 10 to 14 days. Okay, but it has to be double dose. Normally you take 400 mg, this will be 800 mg. So that will be the treatment. When will you drain amoebic liver abscess? Indications for drainage, MCQ. If it's very large, more than 5 centimeters, or it is at the surface, subcapsule, at the surface, or okay, at the surface, or it is in the left lobe, or not responsive. Why are you draining only in this case? What is the problem in all of these? Very nice, excellent. They are at risk of rupture. Okay, at risk of rupture. Because left lobe is very small. Normally, left lobe is very small. So an abscess in the left lobe, however small it is, will very easily burst. That's why. आई बात समझ में? So these are all conceptual things. You know these concepts, you don't have to mug these indications. How many indications will you mug, right? कितना रटोगे? कहीं ना कहीं थोड़ा logic, you will get. These are easy questions in surgery because trust me, hepatobiliary is the system all students fear. They are like nahi samajhta. If it rupture, obviously you have to remove it. Goes without saying. So these are some of the systems. If you get it comfortably, you are sorted. Okay. Loculated cyst was hydatid. This is abscess. Loculated is like multiseptate. Obviously, you have to remove it. Surgically, you can't do pair in that case. So their pair will not be possible if there are multiple. Okay. But here we are talking about abscess. Okay. Since Akriti asked Moini and hump. So see Akriti, before you ask the question, I have the slide ready. Even before you asked. Landmarks in cholecystectomy. Okay. So I hope you didn't ask the question because you knew what the next slide was. What will happen to the abscess? No, the liquefied liver will get drained off. That's it. So that part of the liver will regenerate or it will fibrose. Yeah, it will fibrose. That's it. So what are the landmarks in cholecystectomy that you must know? So when you are starting cholecystectomy, what do you identify first? Yes, what do you identify first? So first, good look at this image. This is the liver. This is the gallbladder. You first push up in the gallbladder. And This is the area you want to dissect. That area is called Callet's triangle. Okay, important landmark Callet's triangle. I am telling you the original Callet's triangle, which you are going to answer in the MCQ. This is the Callet's triangle, cystic duct, cystic artery, common hepatic duct. है ना? Common hepatic duct, cystic duct, cystic artery. This is the original. Okay, this is from Bailey, exactly from Bailey. Callet's triangle, initially described by Callet. Cystic duct, common hepatic duct, superior border of cystic artery. Okay, ये बेली में दिया है, बेली की फोटो है. But I can't see all that over here. Where is the duct? Where is the artery? I can't make out. So what I see is this. That is called as Rouvier sulcus. Rouvier sulcus. From the sulcus, I draw a horizontal line. That is called R4U line. Now, why am I looking at this line? I have to dissect above the R4U. Okay, this is the area which I need to dissect. Don't dissect below, it is dangerous. So you dissect the R4U line. R is Rouvier, 4 is segment 4B, U is umbilical fissure. इसके ऊपर. Now when I do all this dissection, finally I get a picture like this. Okay, I get a picture like this. So first you identify the Rouvier sulcus, draw a horizontal line through the sulcus and dissect above. Don't dissect below. Once I have dissected above, I will get a picture like this, where I am seeing the cystic artery. This is the artery, the cystic duct entering the gallbladder. So what I'm visualizing, cystic duct and cystic artery entering the gallbladder. This appearance is called critical view of safety. Okay, critical view of safety. You must get this view. It is a prerequisite step. Okay, it's a prerequisite step before doing any clipping, tying and cutting. So till I don't get the critical view of safety, I have to do this much dissection. Once this dissection, this is like the end point of my dissection, then I can cut and remove the gallbladder. Now, sometimes, now where does the cystic artery come from? What is the origin of the cystic artery? Where it is coming from? The cystic artery. Yeah, it is coming from right hepatic. So here is the common hepatic. Then I have the right hepatic, which gives the cystic artery. Okay, then I have left hepatic. Sometimes the right hepatic artery comes in the Callet's triangle like this. And it will give a very small cystic artery. So if I see a very tortuous right hepatic artery coming in the Callet's triangle, that is called as Moynihan's hump. So it is a tortuous right hepatic artery which comes in the Callet's triangle. That is called as the Moynihan hump. What is Moynihan? Moynihan ये नाम कहाँ से आया? What is Moynihan? सुना है क्या नाम? He was a lord. He was not a surgeon. His name is Lord Moynihan. Okay, very big guy who found this hump. That is why there are many things in surgery named after Moynihan. Many things. Moynihan clamp, yes. Moynihan forceps, Moynihan scissors, and Moynihan hump. Okay, Lord Moynihan. And this is the Callet's triangle. Okay, but now they have changed the Callet's triangle where they include inferior border of liver, but that is a modification. In the exam, this is what you can use as a reference. Okay, correct. Yes. Now what they use is hepatocystic. That is the name of the triangle that we use in surgery, hepatocystic. But I don't want you to confuse with that. Now come to bile duct injury. When do you get bile duct injury? Very IMP topic for INI-CET. Popular INI-CET topic. This happens usually during cholecystectomy. Usually during cholecystectomy. So all this you are doing was to prevent bile duct injury only. Because during cholecystectomy, if you do some wrong thing, you don't identify these landmarks, you may end up injuring the bile duct. So first you need to understand bile duct means what will get injured and what things come in the area of the biliary anatomy. So the bile duct starts as the right and left hepatic duct. This becomes the common hepatic duct, which receives the gallbladder and the cystic duct, and this becomes the CBD. Okay, which you are seeing here. But this right hepatic duct actually has two branches. You can see over here, common hepatic, left hepatic. This is the right duct. This horizontal right duct is called as right posterior duct. Okay, this vertical one, that is right anterior. Left is single. Then you have common hepatic. This is the area of Callet's triangle. Which duct do you think will get injured? Usually in cholecystectomy. What do you think will get injured? Usually cystic duct can get injured because it's right there. Common hepatic duct can get injured. Right posterior duct can get injured. They are the three which are commonly injured. होने को कुछ भी injure हो सकता है. Sometimes even CBD gets injured. But normally it won't come in the way. Okay, should not come in the way. CBD in this image, can you see the CBD in this image? दिख रही है क्या CBD? Normally you can't see CBD. It will be somewhere here. Okay, that is where the CBD will be. You should not be able to go till there. Okay. Now, when these things get injured, they will get injured in two ways. There are two ways in which they get injured. One is bile duct is cut. Other is bile duct is either tied or burnt by mistake. Usually. Okay. If it is cut, the person will get bile leak. If there is bile leak, he will get a peritonitis, bilioma. This is called as acute bile duct injury. Okay, short form I'm writing BDI, acute bile duct injury. If the bile duct is burnt, like let's say by mistake, I coagulated the common hepatic duct, I didn't realize. Then over a few weeks or months, okay, over a few weeks or months, there will be stricture. It will undergo narrowing, there will be stricture. So person will present with obstructive jaundice. You know, in jaundice, there are three types: hemolytic, hepatic, obstructive. That is this. He will have obstructive jaundice. This will manifest after a few weeks or months. So this will be called as chronic bile duct injury. Right. This is chronic bile duct injury. In the exam, either they ask you to diagnose or they ask you the management. So now the easy part. This was the tough, the concept. Now you got the concept. Now the answer. How will person with acute bile duct injury present? He will have a history of lap pudding. Usually done 1 or 2 days back. Not a very long history, 1 2 days back, recent. And he will say now he has pain because bile is leaking. He has pain in right upper quadrant. He may have fever. Okay, so these patients you have to watch out for pain and fever just after surgery. What has gone wrong? So you want to know, is there a bile leak? What will you do? to look for bile leak? Obviously, first you are going to do LFT plus USG abdomen. Okay, USG abdomen will show a collection in that area that is called as bilioma. So somewhere here in this area there will be a bile leak collection that is called bilioma. What to do when you see the collection? What will you do? You have to first, means the next step is going to be drain the collection because it is forming an abscess. It's like an abscess. So drain. Either put a pigtail or do surgery and drain the bile which is leaking out. Put a tube to leak the fluid out. So either you do pigtail drain or surgical drain. And then you wait. Wait for the patient to stabilize. Do some imaging. Why are you doing imaging? Vacuum nahi, suction drain. You can put suction drain. You want image because you want to know the site. Right? You want to localize. So you can either do MRCP or ERCP. Okay, both are okay. Different scenarios will warrant different next step. My answer will be MRCP as the next step. If they ask you best, then you can do ERCP. CT is not for site of leak. For site of leak, I need a biliary imaging. MRCP, ERCP, both are okay. This will tell me the site of leak. And based on the site of leak, I have to decide the management. Okay, it is based on the site of leak. How do you classify sites of leak? And what are the possible sites of leak? So you follow this classification. This is called as Strasbourg. Okay, this is called as Strasbourg. What he says, acute bile duct injuries, he calls them as type ABCD. So ABCD are acute. And chronic are E, type E, which is also called as bismuth. कभी याद नहीं रहता नहीं बहुत easy है सिर्फ acute you need to remember. Acute you should know. Okay, because in acute you have type A. A is this, where the bile is leaking from here, the cystic duct. So in type A, there is a cystic duct leak. Okay, this is the most common type of biliary injury, cystic duct leak. So first, this is one. HIDA can be done, but no, in today's day and age, nobody does HIDA. Everybody does MRCP, ERCP. Nobody does HIDA. HIDA is quite outdated. Then you have type B. Now B is acute, but there is no leak because in B, the right posterior duct is by mistake blocked. B for blocked. So in this, even though it is acute, it will not present acutely because here there is no leak. So है तो acute, but leak नहीं हो रहा. It will present as chronic only. Then you have type C, where the right posterior duct is cut. Okay, so you can remember B is blocked, C is cut. And then you have type D, where the common hepatic duct is cut. So normally A, C, D are acute. And why it is like this? Cystic duct, right posterior, and common hepatic, because these are the ones which are likely to get injured. Okay, I told you na, cystic, right posterior, common hepatic. That's what he saw. ये तीन ही injure हो रहे. By mistake block means you thought was a artery and you tied it. गलती से. So by mistake you tied it. So it got blocked. Right. Now why do I need this classification? How does it help me? If it is type A, okay, if it is type A, this can be managed immediately by doing what is ERCP plus stenting. So ERCP plus stenting will treat a cystic duct leak. You just have to put a stent in this. You just have to put a stent in this. The leak will stop. Nothing more needs to be done. But for the other types, that is type B, C, D, you are going to wait for a few months, few weeks, 2 months. Let it form a stricture and do a delayed repair. Okay, you will do a delayed repair. That is how you will manage. So A, B, C, D differ in management. Of course, they differ in severity. Most of the times it will be type A. But see, people always ask me MRCP, ERCP. Till then you have to keep, yes, you have to keep the drain till it is leaking. So this is a line from Bailey. MRCP is the gold standard for morphological evaluation. Okay, it is helpful in determining the level and degree of injury. Because many teachers will tell you it is ERCP. In fact, even gastrosurgeons will say ERCP. But this is the line from Bailey. Now it is up to you how you want to choose, what answer you mark. Okay, because I feel it should be MRCP, but it's up to you. I've given you the reference, so you can use this. But examiner can use some other reference, so examiner can change the answer. That is taking a chance, but this is the reference. This is from Bailey. The other part is easy. Chronic bile duct injury is very easy to understand. Here, patient has history of lap coli few months ago. Right? He has a history of lap coli, which was done few months back. It will not be acute, it's chronic, no? And now he comes with obstructive jaundice. So he will come with jaundice. But it will be late. What else findings will he have apart from jaundice? If question asks management, then ERCPS goes without saying. So he will have jaundice, pruritus, clay-colored stools, dark-colored urine. All these are findings of obstructive jaundice. He'll have clay-colored stools, dark-colored urine. Any person with obstructive jaundice, what do you do first? First, you do LFT USG. Anything you will see on LFT? You will see elevated alkaline phosphatase, marker of obstruction, elevated direct bilirubin. Right? These are markers of biliary obstruction. Now you want to know the level of stricture. So the investigation of choice here is only one. Here there is no doubt. Here it is only one. Here it is MRC. Okay, here there is no ERC. Here it is MRC. And based on MRCP, you will do a surgical reconstruction. Okay, so this is very easy. There is a biliary narrowing. It will require some kind of a reconstruction when it is diagnosed. Investigation of choice is MRCP for biliary imaging. Gold standard for bile duct injury, ERCP, yeah, okay, fine. No problem. You can call it that. That's fine. But imaging should be MRCP. Okay, if they use the word imaging, evaluation of biliary tree, it should be MRCP. Yeah, hepaticojejunostomy, correct. Okay. Now, there are two more names you should know. Apart from Strasbourg and Bismuth, Hanover and Stuart Way. Hanover came in INI-CET. It was a very tough question. Hanover is a classification of bile duct injury, which includes vascular trauma. Which vessel is injured? So it includes vascular trauma. What is the Stuart Way? What does it include? It includes laparoscopic injury. Okay, it accounts for laparoscopic biliary injury. Okay, just some names you should know. Hanover, they've already asked. See, if it is diagnosed early, it doesn't matter. What matters is from where it is leaking. If it is cystic duct leak, the treatment will be ERCP. Period. For other types of leaks, there are a lot of factors whether you will do early surgery or late surgery. No, don't. No, don't need to know Hanover Stuart Way. You rather know Strasbourg and Bismuth well. Because if they are Strasbourg or Bismuth and you don't know, you lose out. But if they ask you Hanover and Stuart Way and you don't know, it's okay. That's not your fault. But not knowing Strasbourg is a fault. Means that is a question you should not miss out. So be practical about what you can remember. Right? Answer this. Right. Golden question. This has come in INI, it has come in NEET also. Patient has chronic abdominal pain, multiple calculi in the gallbladder, dilated CBD. What should I do? What should I do? So to understand this, I'll give you one logic which I have given 100 times. 100 times I have given. Whenever I say biliary imaging or biliary investigations, first I always start with LFT USG. That is the first imaging in any hepatobiliary condition. When do I do MRCP? Use these words. If you see these words, that person has LFT, which is deranged, like increased alkaline phosphatase. So they tell you person has gallstones, but his alkaline phosphatase is elevated. Or they say USG shows dilated CBD. You see any of these words? Or suspected biliary disease. Suspected biliary disease, including bile duct injury, you will do MRC. When will you do ERCP? If you see that you can visualize, not suspected, visualize CBD stones or bile leak, and you want to treat it, especially type A. In that case, you will do ERCP. So now if you see the earlier question, it is not telling you why the CBD is dilated. I don't know why. See, obviously, you know why. You will feel the gallbladder stone has gone in the bile duct. That's what you will say, na sir. Obviously, it is gallstone. What if it is not? What if it's not a gallstone in the biliary tree? कुछ भी हो सकता है ना, जरूरी नहीं है. It may be a tumor also. It is dilated, I understand, but what if it's dilated due to tumor? I'm not sure. So though there are stones here, I don't know what is here blocking it. To confirm, I will do a MRCP. If MRCP says yes, there is a stone. चलो मान लिया MRCP पे मिल गया stone. Then to remove the stone, I will do ERCP. ERCP can visualize, but ERCP has complications. ऐसा नहीं है ERCP will not pick up the stone, but the complications of ERCP are too much, like pancreatitis. So if I can avoid that, why not? And if I can avoid that, see, when you are studying, you want to study from mission videos. You don't want to do from main videos. Why? Because you feel mission videos will do your job. Okay, now so you are relying on your lab 2. Some of you are like, sir, lab 2 काफी है क्या? Because you feel it will do the job. काम हो जाएगा. You have a system, there is a timetable, you don't have to rely on anything. हो जाएगा. Mission will have more matter, obviously. But उतना चाहिए क्या? और मिशन करने जाओगे दिमाग मेन वीडियोस करने जाओगे दिमाग खराब, बोरिंग, so many 70-80 hours of every subject. कौन करेगा? Do mission. Okay, simpler, no complications. You can curse the teacher on his face and he will not say anything. Right? ऐसा भी करते हो आप लोग. With due respect लिख के माँ बहन की गाली देते हो. That's what you do. It's okay. जिस दिन टीचर का मूड खराब होगा वो आपको he will give it back. Right? So मत की एक बात, MRCP is safer, so it is diagnostic. This is not what I say. ERCP is to treat. So everyone always says, everyone, sir, the calculi and the gallbladder only have gone in the CBD. But that is an assumption. That's an assumption. So proof is MRCP. If MRCP shows yes, there is a stone, then I will do ERCP and remove the stone. Okay, means I'll put a endoscope here, see the stone, put some instruments from the opening, like a basket, and remove the stone. Okay, so I remove the stone by ERCP. Is it possible that I can't remove the stone by ERCP? What happens if ERCP fails? If ERCP fails to remove the stone, its stone is very big. It's not coming out with my basket. So if ERCP fails to remove the stone, in that case, I do a surgery to remove the stone. That is called as CBD exploration. So I open the abdomen. I see the stone. Okay, there is a big stone here. I see it. I open the bile duct, remove the stone. That is called CBD exploration. Many times when I do CBD exploration, at the same time, when I close the CBD, I put a T tube. So someone was asking, na, when do you put T tube? T tube is done when I do open surgery of the bile duct. To protect the bile duct, I put the T tube. But when do I do open surgery? If the stone is not coming out. Usually this will be a stone more than 1.5 centimeters. Or the stone is very high up in the bile duct, where my endoscope is not reaching, the instruments are not reaching. High up stone. जैसे आप सैटरडे संडे बहुत नशे में थे, you are very high up there. Then your friends could not control you. Then what do? If they can't control you, they call your parents. Parents will come slap you, bring you down to earth. So that's open CBD exploration is like your parents. Yeah. Won't CBD stricture develop after open abdominal surgery? Normally, no. It should not develop. Okay, should not develop. Right? To see baat mein answer this. GB also, yeah. Whatever it is, cholecystectomy has to be done. Yeah, whatever it is, you have to do cholecystectomy because the stone has come from gallbladder. Goes without saying, cholecystectomy is a part of treatment. So see this, a sizable stone is detected within the CBD. Here they are telling you, there is a stone in the CBD. Here the answer will be ERCP. And after ERCP, you will do a cholecystectomy. Okay, after ERCP, you will do a cholecystectomy. Cholecystectomy has to be done. That goes without saying. Right? T tube I put in the bile duct when I have opened the bile duct. It's nothing to do with ERCP. When I do open surgery, that is when I will put a T tube. Like if your parents come because you are stoned, because your friends couldn't control you, and then they slap you and tell you, okay, now calm down, sober up, then what will they do? They will put some restriction. They will say, 1 month you can't go out. That is the T tube. T tube is like the punishment to ensure you don't do masti again. Yeah. For Mirizi, you want to prove Mirizi, you will do MRCP. To prove Mirizi, it is MRCP. Octogenarian. Octo means 8. So a woman in her 80s. In OPD CBD exploration, we will do cholecystectomy. Yeah. If you are doing open CBD exploration, that means there is a stone which has come from the gallbladder only. You have to do cholecystectomy. It's a part of treatment for CBD stones. Right. Choledochal cyst, very easy disease. What's the size of what? 1.5 centimeters or more usually will not come. Usually. Choledochal cyst is a congenital biliary dilation. Okay, it's a congenital biliary dilation. Now, why is it dilated? We don't know, but there is one theory. It is called, very nice, Mohan Raj, you know the name. It is called AUPBD. That's the name of the theory. Very important. Anomalous union of pancreaticobiliary ducts. Okay, anomalous union of pancreaticobiliary duct. That is the name of the theory. Yes, cholecystectomy even after success of ERCP, guys, it is correct. CBD में stone है तो गॉल ब्लैडर निकालना ही है, बात खत्म. Interval usually within 1 or 2 days. It is usually immediate, 1 or 2 days. Now, there are different parts where you can get choledochal cyst. It is given by a classification called Todani. This is the classification you should know. Todani classification. And what does the classification say? Type 1 to 3 are where just CBD is dilated. Type 1 is fusiform dilation of CBD. Okay, like you are seeing over here. That is fusiform. Type 2, the dilation is sideways. It is coming from the side diverticular. Type 3 is the terminal CBD. Okay, which is the intraduodenal CBD. Just the last part, also called as choledococele. Okay, also called as choledococele. Arunav, same like ureterocele. Where did you hear that? Type 4 and 5, they are diffuse types. In type 4A, there is dilation of intrahepatic and extrahepatic bile ducts. So it's a diffuse dilation of intrahepatic and extrahepatic bile ducts. In 4B, there is a dilation of only extrahepatic bile ducts, and in type 5 it is dilation of only intrahepatic bile ducts, also called as Caroli's disease. Now they will ask you the types, or they will ask you the presentation. Okay, so usually it will be a young girl, not young like you, huh? A child. It's a pediatric disease. A young girl, usually in the first decade of life, who comes with pain plus lump plus jaundice. Okay, not as young as you are. Huh? You are safe from this disease. So they will come with jaundice, pain, lump. You will do LFT USG. What is the investigation of choice? To confirm the type of choledochal cyst. Investigation of choice, MRC. Okay, investigation of choice, MRCP. Treatment for all is going to be remove the cyst, except one. In all of these, you have to remove the cyst because it is pre-malignant, except one. That is type 3. Because in type 3, the dilation is here inside the duodenum. Very difficult to remove it. Okay, very difficult. So only for type 3, the treatment is not excision. The treatment is ERCP plus cyst drainage or cyst deroofing. You may have to do a sphincterotomy also. But the idea is this is the one. Yeah, it's marsupialization, correct. Where you are not going to just remove the cyst. You are going to drain the cyst. Cyst won't be removed, it will be drained. So in type 3, risk of cholangiocarcinoma is still there. For all the other types, cyst has to be removed. Yeah, obviously for 4A and 5 goes without saying. Now, you also have to remove part of the liver. In fact, the whole liver. So 4A, 5, it will not be only liver transplant, it will be excision with liver transplant. पहले तो आपको cyst निकालने पड़ेंगे ना liver के साथ. So it will be hepatectomy with liver transplant. Okay, for 4A, 5. But the logic is, if you know the types, you should know the treatment. And you should know for type 3, you don't do excision because it's very difficult. Okay, that is the message. Now, one of our Kasai is for biliary atresia. It's not over here. Kasai is for biliary atresia. It's a pediatric, it's a congenital disease. वो आपको pediatric में पढ़ाएंगे. उधर आता है Kasai. Sphincter will be gone. Yes, when you do sphincterotomy, sphincter is gone. Means it is damaged. Okay, now 4B, you just do excision and reconstruction. In 4B, you remove all this and you do the joining. Means you do a hepatico-jejunal anastomosis. That's a type of reconstruction. Yes, sir. Most common cause of acute pancreatitis. Type treatment, hepatectomy with liver transplant. Most common cause is biliary stones. Means gallstone which has gone in the bile duct. It's more common than alcohol. Huh? It's more common than alcohol. Alcohol is the most common cause of chronic pancreatitis. Pancreatitis causes some complications that you should know, known as Atlanta classification for local complications, right? So when I get pancreatitis, first the pancreas becomes edematous because of inflammation. It starts with that. Then sometimes the enzymes of the pancreas degrade. So the enzymes are outside. These enzymes get diluted by the peritoneal lining and they form what are called as acute fluid collection. And what is this fluid collection rich in? What does it contain chemically? The pancreatic enzymes, amylase, lipase. If the leakage continues and it doesn't stop it, then all these fluid collections, they start coming together. They start getting organized and they form a wall, an inflammatory wall. So if they persist for more than 4 weeks, that is called as a pseudocyst of pancreas. Okay, that is called as a pseudocyst of pancreas. If they ask you most common site of pseudocyst, it will be the space around the pancreas, which is called as lesser sac. Right? It is called as lesser sac. Now, sometimes when there is pancreatitis, part of the pancreas dies. There is some necrotic debris. So that dead pancreas is called necrosis. If this necrosum goes in the fluid collection, that is called as acute necrotic collection. So acute necrotic collection is nothing but a acute fluid collection with necrosis. And the same fluid collection, if it forms a pseudocyst, it is called as wall of necrosis. Anybody wants to answer Moshe's question? Can I get elevated amylase lipase without pancreatitis? Oh, okay. Yes, it can increase. When? How? How? How's that? Amylase can be raised in many conditions, not only pancreatitis. It is non-specific. Yeah, bowel perforation, obstruction, salivary disease. Lipase will not be elevated. Lipase is specific. Amylase is not. So I'm happy you guys gave that answer using your brains. Very important in surgery. Right. Good thinking. So who gets acute pancreatitis? There will be history of gallstones, or there will be history of alcohol drinking, binge drinking. Learn from the best is not me, na? Show you. I don't know who you mean, but okay. Complaint of epigastric pain radiating to back with tenderness at epigastrium. It's a very classical presentation. Epigastric pain, radiating to back, relieved on bending forwards, tenderness at the epigastrium, nausea, vomiting. Sometimes if there is hemorrhage, you get these signs like Cullen sign or Cullen sign. This is the one where you get paraumbilical bruising. No, it's not tripod position. Huh? Tripod position is used somewhere else. Anybody can tell? When does person sit in tripod position? Epiglottitis. I don't know about that. It is in I don't know about epiglottitis. It is in COPD. COPD person sits like this in tripod position. Why? Why he sits in tripod position? Great Turner sign is flank bruising. To expire more, easy air out, relieve obstruction. No, it is to enable him to use the accessory muscles. That is the answer. Some of you have said. So it helps him use his accessory muscles. कुछ भी भलते आंसर नहीं देना और ऐसे बिल्कुल मत सोचना मेरे को मेडिसिन नहीं आती. So flank bruising is great Turner sign. Where has this blood come from? I mean, it is peripancreatic, but how has it come there? Yeah, he feels better on leaning forward because the inflammatory enzymes move forward. Dependent. Umbilicus is not dependent, but how pancreatic bleed has reached till there? Or is it that someone has given a box, punched him there? Bleeding is around the pancreas. How has the blood come till there? No, not splenic artery. It is hemorrhagic. But how has it reached? It is because the blood from the retroperitoneum enters the abdominal wall. And from the abdominal wall, it migrates anteriorly. It is just like what I will teach you later. Those signs that you see in the eyes in anterior cranial fossa fracture. Anterior cranial fossa fracture, raccoon eyes. There was no injury on the eyes. The fracture, base of skull, blood tracked forward and came over there. Raccoon eyes, panda sign. It's the same. It's just like that. Okay. See, when there is only pseudocyst, okay, when there is only pseudocyst, means there is no necrosis. If there is necrosis in pseudocyst, it is called as walled off necrosis. That's the only additional point. Dependent part is retroperitoneum. Na? Retroperitoneum cannot go intraperitoneal. It's very difficult. It's easier to go in the abdominal wall. Easier. It's not necessary. It's just easier. Right. Now come to investigation severity. You are suspecting pancreatitis. What do you do first? First step. You have two choices. You can do amylase. This question came in INI-CET. You can do lipase. Amylase rises early, but it is non-specific. Okay, it is non-specific. Usually rises within 4 to 6 hours. Lipase rises after 12 hours, but that's okay. It doesn't matter. Most patients will not come so early. It is very sensitive and specific. If you have to pick one, it is serum lipase. Okay, it is not amylase. It is lipase. If you have to pick one. And remember, none of them relate with the severity. They don't tell about severity. Okay, they don't tell about severity. Which means if a person's lipase is 3000, does not mean very severe. Not at all. It does not relate. Imaging of choice is CECT abdomen, but you don't always need it. The role of CT is not for diagnosis, it is for severity. And usually it is done after 72 hours of what? After 72 hours of symptoms. So if person comes with 1 day history of symptoms, you feel it is pancreatitis, it's biochemical. Lipase elevated, pancreatitis. You don't need CT. Wait for 2 days. After 2 days, means total 3 days from symptoms, that's when you will do CT, because if you do early, it may underestimate the severity. It may underestimate the necrosis. Okay, necrosis may be understood. That's why you have to wait for 72 hours. By then, necrosis will be well established. Now, apart from CT severity, there is another thing you can do for severity. Yeah, if it is more than 10, it is called CT severity index. It's out of 10. If it is greater than or equal to 7 out of 10, it means it is severe. But what is more practical is the modified Atlanta classification. Mild, moderate, severe. Very simple classification. What is mild, moderate, severe? Mild means no complications. Moderate means local complications like local complications like local complications like acute fluid collection, necrosis, or person has a organ failure which responds to treatment. Organ failure response to treatment means it gets okay within 48 hours. SIRS is not a part of Atlanta. No. Severe means he has organ failure persisting for more than 48 hours. How is pancreatitis connected to organ failure? Splenic vein thrombosis is a local complication. How is he getting organ failure? No, there is no best. There is nothing best in this. 48 hours since treatment. Since you have started treatment. How is he getting organ failure? It is because of sepsis. But why is he getting sepsis? It is due to infected necrosis, usually. If the necrosis gets infected, he will get sepsis. So it's a very good, simple classification to use. Other score you can use is BISAP. Stands for bedside index in severity, where B stands for elevated blood urea nitrogen. I is impaired GCS. If the GCS is less than 15, S is present of SIRS. A is age more than very nice 60 years, and P is presence of pleural effusion. If any 3 out of 5 or more are deranged, it means the person has severe pancreatitis. What is the advantage of this score? How it is better than Atlanta? Very nice, can be done at any time, can be done anywhere. It is done bedside. And you don't have to wait. You can tell person is severe right now. After 1 day, you can repeat it to see has he become from severe to non-severe. Very easy test. Ranson score used to be done in the past, not done anymore. GCS below 15. Below 15 means anything below 15 is impaired. So Ranson used to do a lot of tests. You would do 5 things on admission. 6 parameters after 48 hours. Atlanta needs CT. To look for local complication, you need CT, na? That's how you will know local complication. Hai 6 after admission. So there are total 11. If 3 or more are deranged out of 11, person has a severe acute pancreatitis. Okay. So these are some of the scores, but at least modified Atlanta, BISAP. They are the very least scores you must know. Very important for exam also, for practice also. Okay. Which one we use in practice? We use multiple scores. So both of these can be used because they are kind of interrelated. No? So you use both. Then you come to chronic pancreatitis. How it is different from acute? How it is different from acute? Most common cause, correct, alcohol. How it is different from acute? Should we remember normal values of, yeah, but that is biochemistry. It's not surgery. Yeah? Normal values you should know for biochemistry. Yeah, in chronic pancreatitis, there is a irreversible change in the pancreatic architecture. It's an irreversible damage. And obviously it's over a period of time. So because of the damage, because of the inflammation, person has a chronic pain, long duration. So he will have pain of long duration. He will become analgesic abuser. Does pseudocyst? No. It is not drainage. It is drain into a GI organ. That is called internal drainage. Okay, that is called internal drainage. So he will become a analgesic abuser. He may also have, if a lot of pancreas tissue is damaged, no, not important, at least not from surgery. Other than that, he may have diabetes because of endocrine loss. He may have steatorrhea, malabsorption. Okay, steatorrhea, malabsorption because of exocrine loss. So these are some of the problems, but the main problem is going to be pain. Amylase lipase usually will be normal. If elevated, they may be just marginally elevated. Okay, marginally elevated. So this is a difficult thing to diagnose because the symptoms are non-specific. Pain, 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 pain. How will you think that it is pancreatitis? You won't think, no, you will think it is peptic ulcer, something like that. So symptoms are non-specific. By chance, you may do a test in the feces, which is fecal elastase. It's not very commonly done, but it's a good test. It will be decreased or it may be absent because it's a marker of pancreatic function. And imaging, there are many imagings. You can do CECT. You can even do MRCP. Both are okay. CECT is a good first test, which will tell you the pancreatic damage, like you see here. Calcified pancreas. Calcified pancreas. Why steatorrhea? Because of loss of or reduced pancreatic enzymes. It's a exocrine failure of pancreas. Right? That is why. Is NCCT not good? NCCT will tell you calcification, but it will not tell you other problems like duct. Okay, it will not tell you duct. So if there is a duct stricture, you will not know. Atrophy also not very good. So CCT is better. You can do MRCP also. Now, how do you treat? What is the treatment for chronic pancreatitis? Can ERCP? Yes, it can cause in 3% cases. It's the most common complication. The treatment is pain relief. Plus, you will control sugar. So for diabetes, plus you will give him enzyme supplements because he is having steatorrhea. So usually you will do conservative management. But with conservative management, if the pain does not go with medical management, pain is not going, only then you will do surgery. Remember, surgery is done for pain relief or pain management. It is not to treat chronic pancreatitis. If you want to treat chronic pancreatitis, there is only one thing you can do. If I ask you surgery of choice for chronic pancreatitis, what is the answer? It is pancreatic transplant. He needs a new pancreas. But how many people get it? It's very rare. So treatment of choice, if I'm doing surgery, is only for pain control. Because sugar I can control medically, enzymes I can give, but how much pain relief can I give him? So whatever surgeries I will tell you are for pain. And what surgeries you do, this is a NEET PG question, depends on the type of the pancreatitis. If the pancreatitis is localized, okay, if it is localized to some part, like let's say it is localized only to the head of the pancreas. He has inflammation, calcification only in the head, nowhere else. Then what I do what is called as head coring. Okay, I perform a head coring, also called as BEGER, Beggar's procedure or Beger's procedure. Okay, that is called head coring. He is analgesic abuser, and so you have to give him higher analgesics. You can localize on CT, like you see this photo, na? You know where the disease is. it is a calcific pancreatitis throughout the pancreas. However, if the disease is involving only the ducts, yeah, inflammation causes pain. The pain is because of inflammation. If the problem is in the ducts, so usually you will see a dilated duct with stones. That is the other type. So there will be stones in the duct. In this case, what you are going to do is you will join the jejunum to it. This is a drainage procedure. So you join the duct to the jejunum. That is called as longitudinal PJ. Okay, longitudinal pancreatico-jejunostome, also called as Puestos procedure. What to do if person has both? If he has head inflammation and stones in the duct, then what to do? If both problems you can do combined, that is called as Fraise procedure. Okay, means head coring भी करेंगे और PJ भी करेंगे, दोनों करेंगे. That is called head coring with LPJ. So surgeries for chronic pancreatitis depend on the anatomy of the chronic pancreatitis, and if you can't control the pain, dual is rarely done. These are the commonly done procedures. These are the ones that they do. And remember, if it is a diffuse pancreatitis, then the best thing you will do is a pancreatic transplant. Okay, cool, fine. Okay, so we'll take a little break now. 15 minutes break. Please be back in 15 minutes. Then we'll start with trauma. Okay, so please be back 7:05 p.m. Drainage is needed. Is there a cutoff? No, it is for pain. There should be stones and you should have pain which you are not able to control. Then you will offer drainage. Very simple.